Welcome to Pharmacology case studies. We are going to start heart failure case studies, and the answer keys and their explanation will be present in the presentation. The presentation link is given below. You can see the notes section. Now, a patient is newly diagnosed with HFrEF, that is heart failure and reduced ejection fraction, and is asymptomatic, which is the most appropriate drug to initiate for symptomatic and survival benefits. Dobutamine, furosemide, lisinopril, sacubitril / valsartan. Now here correct option is C. ACE inhibitor should be initiated in all the patient unless contraindicated. So if they have HFrEF and are asymptomatic, this is known as stage B HF. So dobutamine and furosemide here will improve symptoms only, and the combination of sacubitril and valsartan will replace an ACE inhibitor if the patient remains symptomatic or on optimal pharmacotherapy. Next, which of the following statement best describes the action of ACE inhibitors on a failing heart? Reduced preload. Reduced ACE inhibitors will decrease vascular resistance, decrease preload, decrease afterload, and increase cardiac output. ACE inhibitors blunt aldosterone release. A Hispanic man with HFrEF currently takes maximally tolerated doses of metoprolol, succinate, and enalapril. Along with moderate dose furosemide, he is euvolemic but continues to have HF symptoms. The systolic BP is low, but the patient does not have the signs and symptoms of hypotension. Which is the best recommendation to improve HF symptoms and survival for this patient? Stop enalapril, wait 36 hours, and start sacubitril valsartan. Start digoxin or start fixed dose hydralazine and isosorbate dinitrate, or start spironolactone. Now see here, because the patient is on optimal pharmacotherapy and continues to have symptoms, so another agent is warranted. Low dose spironolactone is unlikely to decrease the BP and will confer a survival and symptomatic benefit. Changing to sacubitril valsartan will likely worsen and the low BP. Digoxin will only improve symptoms and not the survival. Fixed dose hydralazine and isosorbate dinitrate will be appropriate if the patient were African American. So here we have to start spironolactone. Next, beta blockers improve cardiac function in HF by decreasing cardiac remodeling. Okay, it seems counterintuitive to decrease heart rate in HF, but beta blockers will improve cardiac function by slowing heart rate, decreasing renin release, preventing direct effects of norepinephrine on cardiac muscles to decrease its remodeling. A 70-year-old woman has HFrEF and hypertension. She takes lisinopril and metoprolol tartrate. She feels well and has no cough, shortness of breath, or edema. Which of the following is most appropriate for her drug therapy? Now change metoprolol tartrate to metoprolol succinate is useful here because succinate should be used in HF, and there is mortality benefit shown with metoprolol succinate. Digoxin and ivermectin are not indicated since symptoms are minimal and she has not yet on optimized guideline directed medical therapy, and no reason to change it to ARB, no cough history. A 75-year-old white man has HFrEF and reports stable HF. His current drug therapy includes optimal dose enalapril, carvedilol, spironolactone. What is the best recommendation to improve HF symptoms and survival? So here you see, replace enalapril with sacubitril and valsartan because patient is on optimal doses of HF medication and continues to have symptoms. So you have to replace enalapril with valsartan is the only option. How is spironolactone beneficial in heart failure? It prevents cardiac hypertrophy. Option C. Spironolactone will antagonize aldosterone, which in turn will prevent sodium water retention and cardiac hypertrophy and hypokalemia. Which of the following is important to monitor in patient taking digoxin? Potassium is the most important. Hypokalemia can lead to life-threatening arrhythmias and increased potential digoxin toxicity. Which of the following describes the mechanism of action of milrinone in heart failure? Milrinone is a phosphodiesterase inhibitor and leads to increased CAMP, increased intracellular calcium, increased contractility. So option B, increased cardiac contractility. A 52-year-old African American woman who has HFrEF, she is seen in clinic today reporting stable heart failure symptoms but is having occasional peripheral brightness. Otherwise, vision is unchanged. Current medication regimen includes sacubitril, valsartan, carvedilol, fixed dose, hydralazine, and isocyanates, ivermectin, and bumetanide. What is the best recommendation to minimize the adverse effect of peripheral brightness? Now you see, luminous phenomena will occur with ivermectin only. So adverse effect will be minimized by reducing the dose or discontinuing. So option D, reduce the dose of ivermectin is correct here. Thank you.